Good morning, everyone. Today we are going to discuss about endometrial cancer. Endometrial cancer, as such of the introduction, as of 2023, the endometrial cancer surpasses the ovarian cancer as the most lethal gynecological malignancy in the USA. The increasing incidence of endometrial cancer in developing countries like Japan, Singapore, Costa Rica, and New Zealand, and India are increasing now. The causes for increasing in endometrial cancer incidences because in changes in fertility and reproductive factors like increasing obesity rate, increasing diabetes, changes in contraceptive patterns are some of the causes linked to the increasing incidence. Early diagnosis of endometrial cancer is possible because of the abnormal uterine bleeding in most cases. A very high survival rate can be achieved by surgery and adjuvant chemotherapy of 95% in early stages of cancer. Coming to incidence, the global age standard incidence and mortality rate is 8.7 cases and 1.8 cases per 1 lakh people. The incidence of endometrial cancer in India is very low when compared to Western countries. The average diagnosis of disease of endometrial cancer is, in case of type 1 endometrial cancer, it is 60 years. The lifetime risk of developing endometrial cancer is 2.6%. As coming to epidemiology, uterine cancer is the second most common gynecological malignancy worldwide. Over 90% of uterine cancers are endometrial cancer. Over 4 lakh new cases are reported annually. The incidence and mortality rate are on rise, especially in postmenopausal women. Incidence is increasing by 0.69% early and mainly due to the obesity and increasing rate of diabetes. Coming to clinical significance, endometrial cancer is growing a public health burden. The endometrial cancer incidence is rising faster than other cancer in several regions. Over 50% of cases are attributed due to the obesity and need for preventive strategy targeting metabolic health, and various screening methods and awareness gaps or the lack of standard screening tools and delay in diagnosis. Unlike in cervical cancers, we have pap smear and conventional cytology, and we have HPV DNA testing and all is available. That endometrial cancer have no proper screening tools and no public health awareness of implications of postmenopausal bleeding. And public educations on postmenopausal bleeding as a red flag remains the critical condition. Regarding to survival disparities, high-income countries report 5-year survival rate is more than 90% for early stage, but low-income regions lag due to the late-stage diagnosis. The impact of quality of life in endometrial cancers, treatment as hysterectomy, radiations affects fertility of younger patients and need for personalized care for younger patients. The ultimate is early detection significantly improves that survival rates. We now come to definitions of endometrial cancer. Endometrial cancer is a malignant neoplasm arising from the endometrium. The endometrial cancer occurs during the reproductive age groups and the menopausal age group. Endometrial cancer primarily affects the postmenopausal women. The median age of diagnosis is around 16 years in case of type 1 endometrial cancer. Coming to classification, endometrial cancer is classified based upon the molecular classifications, otherwise called Promise or Vancouver classification. It is polymerase epsilon ultra mutated classification and microsatellite instability hypermuted and copy number low and copy number high. Of that, copy number low is most common, 49% contributions, and microsatellite instability is 39%. And polymerase epsilon is least compared to other molecular classification. Molecular subtypes, Leiden and transport classifications, polymerase epsilon mutated, mismatch repair deficiency, and P53 abnormality, and no specific molecular profile. Approximately 3% of endometrial cancers have more than one molecular features. So coming to based upon classification of histopathology, endometrial carcinoma is the most common endometrial cancer. And we have other types of serous carcinoma, clear cell carcinoma, mixed carcinoma, and differentiated carcinoma. Carcinoma sarcoma is that. Of this, we have to grade in that endometrial cancer based upon if it is histopathology is endometrial carcinoma, but the grading is grade 1 and grade 2 comes to low grade. The same endometrial carcinoma with grade 3 and grade 4 comes under grade high grade. And other histopathology serous, clear cell, mixed carcinoma, undifferentiated carcinoma, carcinosarcoma, all comes under that it is grade 1 or grade 2 or grade 3 or 4 is come under high grade. Coming to classification based upon the endocrine features, it is type 1 is estrogen dependent endometrial cancer, type 2 is estrogen independent endometrial cancer. We are going to discuss about what about the difference between type 1 and type 2. Based upon the clinical features, type 1 is more common in obese patient, metabolic syndrome, and increased estrogen concentration, and hyperlipidemia and hyperglycemia. Whereas type 2 is most common in lean patient. It is not associated with estrogen. Usually type 1 is low grade and type 2 is high grade. And hormone receptor expression in type 1 is positive and type 2 is negative. Histology in type 1 mostly is endometrioid and type 2 is non-endometrioid cancer. Genomic stability is in type 1 is diploid, in type 2 is aneuploidy. And in type 1 is a good prognosis, whereas type 2 is poor prognosis. Other features of type 1 is it is more common around 50 to 60 years of age, whereas type 2 is common in 70 years of age. The risk factors for type 1 is chronic estrogen stimulation and obesity, anovulation, nulliparity, and adult onset darkness mellitus, non-hereditary polyposis, colonic cancer. Whereas type 2 is mostly the most common risk factors atrophy, endometrial atrophy. The precursor lesions in type 1 is atypical endometrial hyperplasia, whereas type 2 is less defined, there is no precursor lesions like that. Whereas coming to genetics, type 1 is associated with P10 mutation, microsatellite instability, KRAS mutations, and beta catenin mutations, whereas type 2 is P53 mutation and HER2 new P16 mutation, P-cadherin mutation. Type 1, the lymph node metastasis, through lymph node metastasis and ovarian involvement in the type 2 mostly peritoneal metastasis. Type 1 is favorable and type 2 is very poor prognosis. Coming to types of endometrial cancer, inactivations of P10 tumor suppressor gene, most common genetic defect of type 1 cancer. The tumors with P10 mutation tends to well differentiated and minimally invasive, whereas microsatellite instability is 20% of coronary cancer and inactivations of MLH mismatch repair system. Type 1 endometrial cancer, KRAS mutation seen in 10 to 20% in endometrial cancer, whereas microsatellite instability and abnormal methylation of MLH are early event in endometrial carcinogenesis in precursor lesions. Coming to type 2 endometrial cancers, P53 mutation is present in 90% of serous carcinoma. Microsatellite instability is very rare, and inactivations of P16 and overexpressions and gene amplifications of HER2 and new oncogenes. Loss of P-cadherin is often associated with advanced stage. Coming to WHO classifications of endometrial cancer, endometrial carcinoma, serous carcinoma, clear cell carcinoma, undifferentiated carcinoma, dedifferentiated carcinoma, mixed carcinoma, and other endometrial carcinomas and carcinosarcomas. The risk factors of endometrial cancers is estrogen is the prime. Excess estrogen or unopposed estrogen is prime cause for endometrial hyperplasia and future it leads to endometrial cancer. Early menarche and late menopause, nulliparity, obesity, metabolic syndrome, polycystic ovarian syndrome, Lynch 2 syndrome, hormone replacement therapy, and tamoxifen are all few risk factors for endometrial cancers. Coming to high unopposed estrogen, the prime risk factors for endometrial cancer is exposure to increased levels of exogenous or endogenous source without adequate apposition of progestins. The endogenous source has chronic anovulations, chronic estrogen production unopposed by adequate progesterone production allows continued proliferation of endometrium. The menopausal transition period and polycystic ovarian syndrome are the examples. In case of obesity, obese patient with high levels of endogenous estrogen, which is precursor for endometrial hyperplasia that leads to endometrial cancer. Estrogen secreting tumors, granulosa cell tumors of ovaries, and early menarche, late menopause mechanism is prolonged duration of exposure to estrogen stimulation. Coming to tamoxifen, is one of the risk factors for endometrial cancer. Tamoxifen is a drug as selective estrogen receptor modulator. In standard dose used in adjuvant treatment for breast cancer, it is known to cause endometrial hyperplasia and polyp, and invasive endometrial cancer and uterine sarcoma, and causes subepithelial stromal hypertrophy, which gives a false impression on endometrium on ultrasound, poor correlations between endometrial thickness and abnormal pathology. The risk of developing endometrial cancer is estimated to be 1.26 per 1,000 patients after 5 years of tamoxifen intake. Coming to Leach-2 syndrome, it accounts for less than 5% of endometrial cancer. Hereditary non-polyposis colorectal carcinoma syndrome. It is an autosomal dominant disorder, a germline mutation in mismatched repair or MLH1 and MSH2 and MSH6 genes, microsatellite instability, colorectal, endometrial, ovarian, gastric, uterine, and skin cancers are associated with endometrial cancer. 40 to 50% lifetime risk of endometrial and colorectal cancer. The cancer tends to occur in pre-menopausal age group as compared to usual type 1 endometrial cancer. Coming to protective factors, progestins, pregnancy, smoking, and physical activity are all protective factors from endometrial cancers. Coming to endometrial hyperplasia is a microscopically defined a crowded proliferative endometrium can be subdivided into non-atypical hyperplasia. It is otherwise known as benign endometrial hyperplasia. And atypical hyperplasia, also known as endometrioid or endometrioid intraepithelial neoplasia. The endometrial hyperplasia is traditionally classified as 4 types. Now it is, according to new classification, this is only 2 types. Traditional classification of endometrial hyperplasia is simple hyperplasia without atypia, it accounts for 1%. Complex hyperplasia without atypia, it accounts for 3%. And simple hyperplasia with atypia is 8%. Complex hyperplasia with atypia is 29%. Coming to this, it is a normal proliferative endometrium, sees that band and all. Whereas in it is simple hyperplasia will be there in case of complex hyperplasia without atypia disorder. Whereas in simple hyperplasia with atypia seen here, where it is complex hyperplasia with atypia. So according to newer classification, WHO 2024 classification, endometrial hyperplasia is classified as 2. One is endometrial hyperplasia without atypia, it accounts for 2%, and endometrial intraepithelial neoplasia or atypical hyperplasia accounts for 19%. Endometrial hyperplasia without atypia is composed of crowded glands lined by similar to semi-normal proliferative endometrium with gland stroma ratios approximately 2:2. Whereas atypical endometrial hyperplasia or atypical endometrial intraepithelial neoplasia, the diagnosis requires glandular crowding will be there like this. Glandular crowding will be there. What is expected? Crowding either cytological atypia beyond what is expected in proliferative endometrium, or morphologically distant subclone of glands are not attributable to benign hyperplasia. Coming to pathology of endometrial carcinoma, Endometrioid carcinoma, it accounts for 80% of endometrial cancer. The gross features vary from polypoid masses to infiltrative flocks to carpets of shaggy tissues. The superficial aspects are typically friable, soft, fleshy, and light tan and light yellow in color. Speckles and geographic islands of past yellow material. This is the gross features of endometrial hyperplasia, what I described previously. Coming to microscopic features, desmoplastic stroma, back-to-back glands without intervening stroma, extensive papillary pattern, and squamous epithelial differentiation will be there. The glands are complex papilla and direct contact with no intervening endometrial stroma, so-called back-to-back patch, like this. So coming to figure staging of endometrial carcinoma, the histopathological grading of our differentiation is grade 1, grade 2, grade 3. Of that, grade 1 is less than 5% non-squamous or non-morular growth pattern, whereas grade 2 is 60 to 50% non-squamous or non-morular growth pattern, whereas grade 3 is more than 50% non-squamous. So less than 5 is 1, 6 to 50 is 2, and more than 50 is 3. So the notable nuclear ATP and inappropriate for the notable nuclear ATP inappropriate for that grading rises grade 1 to grade 2 by 1 grade. In serous adenocarcinoma, cellular KSL adenocarcinoma, squamous cell carcinoma, and nuclear grading takes precedence. Adenocarcinoma with squamous differentiations are graded according to the nuclear grade of the glandular. Endometrial cancer, a villonodular configuration is present in up to 2% of the carcinoma. Secretory carcinoma is a rare variant of endometrial carcinoma that accounts for about 1% of the cases. Most commonly seen in early postmenopausal women. The tumors are composed of well-differentiated glands with the intracytoplasmic vacuoles. It has excellent prognosis. Coming to mucinous carcinoma, it accounts for 5% of endometrial cancer. The predominant mucinous pattern is more than half of the tumor cells is composed of intracytoplasmic mucin. A well-differentiated glandular architecture and good prognosis will be there. Mucinous carcinoma must be differentiated from endocervical adenocarcinoma. So we have to do cervical biopsy along with that endometrial biopsy. Positive perinuclear immunohistochemical staining with vimentin suggest an endometrial origin. Presence of foamy endometrial stoma and presence of squamous metaplasia or presence of areas of atypical endometrial carcinoma. Coming to the microscopic features of mucinous endometrial cancer, the tumor cells form strips and fibriform structures, and many contains delicate bluish and intracytoplasmic mucin. This one, bluish intracytoplasmic mucin, and fibriform spaces in the tumor contain bluish mucin, and numerous neutrophils is there. It is that microscopic features of mucinous cancer. Coming to serous endometrial cancer, about 3 to 5% of endometrial cancers are serous carcinoma of ovary and fallopian tube, also known as uteropapillary serous carcinoma, is considered as very high risk lesions. Most often, these tumors are composed of fibrovascular sacs lined by highly atypical cells with tougher stratification. Some of bodies frequently are observed in serous cell carcinoma of endometrial cancer. Coming to squamous carcinoma of endometrium, is even though it is rare, it is associated with cervical stenosis, chronic inflammations, and pyometra. Because of the cervical stenosis, most of the patients own presents with classical presentation of perimenopausal bleeding or postmenopausal bleeding, and chronic inflammations, and patients presents with pyometra. Sometimes the patients presents with abdominal distension or abdominal mass. So most of the time we can diagnose very late stage. So the prognosis is very poor in this case. The overall survival rate in stage 1 itself is 34%. Serous carcinoma, most aggressive type of tumors, is often associated with the lymph vascular space and deep myometrial invasions. It has high recurrence rate. Coming to microscopic features, branching papillae or supported by delicate fibrovascular pores, and it is lined with columnar cells with moderate nuclear atypism and multiple nuclei and mitotic figures, as seen in this. Coming to clear cell carcinoma, it accounts for less than 5% of endometrial cancer. Clear cell carcinoma usually has a mixed histopathological pattern, including papillary, endotubulocystic, glandular, and solid types. These cells have high atypical nuclei and abundant clear or eosinophilic cytoplasm. Often the cells have hobnail configurations arranged in papillae with islanded stalks. It occurs in older women and has poor prognosis. The overall survival rate varies from 33 to 64%. The microscopic features of clear cell carcinoma is clear cells with clear to eosinophilic granular cytoplasms. The cells are arranged in papillae sheets or tubulocystic structures or some combinations of this, and eosinophilic island globules are common features. Here the cells have clear cytoplasm and distant cell membranes characteristic of this tumor. This is the one, clear cytoplasm with distant cell membranes. The nucleus are moderately pleomorphic with nuclear prominence will be done. Secretory adenocarcinoma must be differentiated from clear cell carcinoma. Both tumors predominantly present like clear cells. About 50 to 25% of adenocarcinoma, endometrial carcinoma with squamous differentiations. Coming to molecular classification of endometrial cancer, currently the most common approach to assessing the subtype of endometrial cancer is to perform both immunohistochemistry and molecular examination of the tumor tissues. Immunohistochemistry enables the detection of abnormal p53 expression and mismatch repair deficiency, while polymerase chain reaction and sequencing methods are used to identify pathogenic polymerase epsilon mutations, the presence of microsatellite instability. So already we discussed endometrial cancers as identified as one of the 4 molecular subtypes. Endometrial cancers with mutations in gene encoding polymerase epsilon is polyMUT, and endometrial cancer with mutation in p53 gene with its deficiency of mismatch repair and high microsatellite instability is coming under microsatellite instability high, and endometrial cancer abnormal expression of p53 protein, and endometrial cancer with no specific profile is classified as NSMP, non-specific molecular profile. Coming to non-specific molecular profile, this is a subtype encompassing the largest and most heterogeneous group of endometrial cancer. It is characteristic by lack of mismatch repair defects, p53 abnormalities, and pathogenic variants of polymerase epsilon gene. Moreover, this tumor is often characteristic by high estrogen and progesterone receptor expression. Non-specific molecular profile is mainly considered as subtype with intermediate prognosis, but it's sometimes associated with poor prognosis. Coming to microsatellite instability, is characteristic as changes in microsatellites length. High microsatellite instability is a marker of predispositions to carcinogenesis, especially of colorectal cancer, including hereditary non-polyposis colorectal cancer, but it's also different tumor types and including endometrial cancer. Coming to molecular mismatch repair, subtype of endometrial cancer is considered a subtype with intermittent prognosis. 4 most common abnormal immunohistochemistry patterns are the loss of MLH1 and PMS2 loss of MSH2 and MSH6, isolated loss of MSH6 and isolated loss of PMS2. Coming to P53 abnormality, P53 is a protein located in the cell nucleus and cytoplasm. It is crucial role in regulating the gene expression, cell cycle, and apoptosis. It is a guardian of the genome. The P53 abnormality is a subtype associated with poor prognosis and highest mortality among endometrial cancer patients. It is usually detected by immunohistochemistry staining for abnormal P53 protein expression, but the determination of P53 pathogenic variants with non genomic stain is also possible. Both strong and absent P53 protein expression in immunohistochemistry examination should be interpreted as a P53 abnormality. Polymerase epsilon is the crucial enzyme involved in DNA replications. It consists of four subunits. The largest one subunit is P261, exhibits both catalytic and exonucleatic activity. P261 is encoded for polymerase epsilon G. During replication, polymerase epsilon is out. It consisting of four subunits. The largest subunit is P261, exhibits both catalytic and exonucleatic activity. P261 is encoded by pol gene, the otherwise called polymerase epsilon gene. During replications, the polymerase epsilon is involved in proofreading, and due to the exonucleolytic activity, the replacement of mismatched bases. Due to the polymerase epsilon gene mutation, the defective activity of pol epsilon leads to increased molecular alterations. Tumors with polymerase epsilon deficiency are mostly microsatellite stable genes. Polymerase epsilon mutations leads to upregulations of inflammatory response, including it's promoting cytotoxic lymphocytic recruitment, and full mute subtype is known to be associated with favorable prognosis. Polymerase epsilon mute endometrial cancers highly infiltrative with T helper lymphocytes with the programmed death overexpression. These results suggest the favorable outcomes of polymerase epsilon mute patients may be associated with high tumor immunogenicity. Coming to clinical presentations, patients present with abnormal uterine bleeding is most common clinical presentations. 90% of the patients present with abnormal uterine bleeding and postmenopausal bleeding, and in case of perimenopausal women, irregular or heavy uterine bleeding may be the first sign. Any bleeding in postmenopausal women warrants a thorough investigation to rule out endometrial cancer as well as cervical carcinoma. The other clinical presentation apart from abdominal uterine bleeding is pelvic pain, pelvic discharge, typically signifies more advanced cases. Occasionally, asymptomatic lesions are discovered intentionally on images performed for some other reasons or may present with abnormal cytological findings on cervical cancer screening. Patient in whom diagnosis of endometrial cancer should be excluded is all patients with postmenopausal women should be do endometrial to rule out endometrial cancer. Postmenopausal with women with pyometra, asymptomatic postmenopausal women with endometrial cells on half smear, particularly if they are atypical. And in case of perimenopausal patients with intermenstrual bleeding or heavy menstrual bleeding, you should be warranted for endometrial cancer screening. And perimenopausal women with abnormal uterine bleeding, particularly if there is history of anovulatory cycles. Coming to diagnostic tools, there are various diagnostic methods are available. First thing in diagnosis, we have to do thorough initial evaluations by history and examination. Thorough gynecological history and complete physical examination should be done. And coming to investigations, we have to do simple ultrasounds. In that, ultrasound shows endometrial thickness is more than 4 to 5 mm is concerning as abnormal in postmenopausal patients. Definitive diagnosis of endometrial cancer is endometrial biopsy. This is a gold standard technique. We can go through histoscopic guided fractional curettage. It is the gold standard method. A direct visualization and direct biopsy when there is high suspicion, but initial biopsy yields insufficient specimen. Coming to epigenetic testing, women cancer risk identifications, quantitative polymerase chain reaction test for endometrial cancer. Other imaging modalities are chest X-ray to rule out pulmonary involvement, lung involvement, MRI to see the metastasis, CT to see the lymph node status, and PET scan to see the distant metastasis. Coming to initial evaluations of endometrial cancer, what is recommended is clinical and gynecological examinations. Transvaginal sonography is must, and biopsy for histopathology. Endometrial biopsy is mandatory to diagnose the endometrial cancer. Chest X-ray, yes, obviously, and LFT involvement of liver and RFT and ascites and all will be the CBC is to be done. Genetic counseling in women less than 15 years in those with family history of endometrial cancer, like I said, Lynch 2 syndrome, non-hereditary polyposis pulmonary cancer. Other investigations are optional, like cervical biopsy or MRI in suspected case of cervical involvement. Tumor marker CA125, MRI, and contrast enhanced CT in suspected extrauterine diseases, and PET CT in case of suspected distant metastasis. Early diagnosis: if women comes with perimenopausal abnormal uterine bleeding, 25% of endometrial cancer occurs perimenopausally, and 5 to 10% occurs under the age of 40 years. Postmenopausal bleeding was also patients present with. So we have to do ultrasound. It is a useful adjuvant to office endometrial biopsy. Is the initial evaluation of endometrial pathology. If endometrial thickness is equal to or more than 5 mm abnormal in postmenopausal women, so in that case, we have to do definitely go for endometrial biopsy either by Piffles curettage as a OPD procedure, or otherwise we can go fractional curettage, hysteroscopic guided fractional curettage. Type 2 endometrial cancers with as having thin endometrium. So patients with abnormal endometrial, patients with abnormal uterine bleeding presents with patients presents to you with abnormal uterine bleeding, but endometrium thickness is less or it is atrophied. So you should not rule out endometrial cancer. That is another type is type 2 endometrial cancer is there. And so by ultrasound, the good negative predictive value is 99%, poor positive predictive value is 57%. So coming to role of Doppler in endometrial cancer, a broad-based lesions with a diffuse high level of vascularity indicate malignant lesions, and single feeding vessels in the stalk of focal lesions with low vascularity indicates benign conditions like pollen. So if it is a diffuse high level vascularity indicates always malignancy. But if it is a single feeding stalk of vessels with focal lesions, usually mostly with endometrial polyps, as in endometrial fibroid. Other uh, diagnostic method is solar histography, good at detecting benign condition, but positive predictive value for cancer prediction is very poor. So this is that ultrasound features. Coming to VT, it is thickened endometrium. You can appreciate this. Endometrial biopsy is that important diagnostic tool for diagnosing endometrial cancer. The first is in evaluations of endometrium. Office endometrial biopsy is Novak curate or Pippel endometrial suction curate and Vabra aspirator. These are all various tools we can use for endometrial sampling in OPD procedure. The success of this procedure is affected by cervical stenosis or alteration of endometrial cavity by submucous fibroids and the size of the lesion itself. The false negative rate is 10%, and further evaluation is recommended if the results come back as normal with persistent symptoms or abnormal pelvic imaging. The pimples and web aspirator devices used for endometrial sampling are very sensitive technique for reductions of endometrial cancer. Coming to hysteroscopic in endometrial cancer screening is a simple office procedure that can provide good visualization of the whole uterine cavity without cervical dilatation, usually without anesthesia. Hysteroscopic guided endometrial biopsy useful in small lesions and in tamoxifen induced thickened endometrium. So we can differentiate with this disadvantages. Dissemination of cancer cells in peritoneal cavity theoretically is proven but not practically proven. Recurrent postmenopausal women should be investigated by endoscopy and hysteroscopic guided endometrial biopsy. The hysteroscopic features of or patterns of endometrial carcinoma. There are pseudo hyperplastic pattern. It has individualized aspect of multiple buds with sharp edges and atypical vascular resolutions. And nodular pattern is fixed nodules with solid aspect and wide base with atypical poor vascularization. And glomerular pattern polypoid endometrium with papillary cell features and containing abnormal neovascularization features with intertwined neovascular vessels covered by thin endometrium. Malignant polyp, a polyp with signs of malignancy, necrotic areas, and fibrin deposition. See here, you can see pseudo hyperplastic pattern of endometrial cancer. You can see hyperplasia, pseudo hyperplasia. And here you can see detailed aspect of pseudo hyperplastic pattern of endometrial cancers with some fibrin deposits. As this are all hysteroscopic views of endometrial cancer. This the nodular pattern appears as a compact nodules with aberrant characteristic vascularizations. This is glomerular pattern associated with tumor high histological grade with advanced disease. This glomerular pattern. This is pseudo hyperplastic pattern. Images similar to CV pattern with individualized papillary and vascularization in each one of them. See here, it is a cotton candy endometrium like representing the tumor necrosis. So here you can see a shape. This is serpinges. This is loop type of patterns. This is irregular diameter patterns and irregular branching of all features of endometrial carcinoma. Other imaging tools in endometrial cancers, Doppler, contrast intensity MRI, and PET scan. It is helped in determining the need for lymphadenectomy, radical hysterectomy, and pre-operative radiotherapy. So coming to figure staging of endometrial cancers, figure staging 2023 done a lot of changes in endometrial staging compared to previous figure staging. Here it comes under stage one is confined to the uterine corpus or ovary. Under ovary. Stage one is this is limited to the endometrium or non-progressive histological type, that is low grade endometrite with invasion of less than half of the myometrium with no or focal lymphovascular space involvement or good prognosis disease. Stage 1 is non-aggressive histological type limited to an endometrial polyp or confined to the endometrium. Stage 8-2 is non-aggressive histological types involving less than half of the myometrium with no focal lymphovascular space invasion. Stage 1A3 is low-grade endometrial carcinoma limited to uterus and ovary, whereas stage B is non-aggressive histological types with invasion of or more than half of the myometrium and with no or focal lymphovascular space involvement. Coming to stage 1C is aggressive histological type limited to polyp or confined to the endometrium. These are all the saline confined to the uterus corpus and ovary. Stage 2 is invasion of cervical stroma without extrauterine extension or with substantial lymphovascular space invasion or aggressive histological types with myometrial invasions. Stage 2A is invasion of cervical stroma of non-aggressive histological types. Stage 2B is substantial lymphovascular space of non-aggressive histological types. Stage 2C is aggressive histological types with any myometrial involvement. Coming to stage 3, It is a local and a regional spread of the tumor of any histological type. Stage 3A is invasion of uterine serosa, adnexa, or both by direct extension or metastasis. 3A1 is spread to the ovary of fallopian tube except with meeting stage 1A3 criteria. Stage A2 is involvement of uterine subserosa or spread through the uterine serosa. Stage 3B is metastasis or distance spread to the vagina and or to the parametrium or to the pelvic peritoneum. Stage D1 is metastasis direct to that spread to the vagina and parametria. Stage 3D2 is metastasis to the pelvic peritoneum. Stage 3C is metastasis to the pelvic or para-aortic lymph nodes or both. Stage 3C1 is metastasis to the pelvic lymph nodes. Stage 3C1 is micrometastasis. Stage 2 is macrometastasis. Stage 3C2 metastasis to the para-aortic lymph nodes up to the renal vessels with or without metastasis to the pelvic lymph nodes. Stage 3C1 1 is micrometastasis, 2 is macrometastasis. Stage 4 is spread to the bladder mucosa and or intestinal mucosa or the distant metastasis. Here 4A is invasion to bladder mucosa or intestinal bowel mucosa. Stage 4B is abdominal peritoneal metastasis beyond the pelvis. Stage 3C is obvious distant metastasis to the any extra or intra-abdominal lymph nodes above the renal vessels, lung, liver, brain, or bone metastasis. Aggressive histological types are composed of high-grade endometrial grade 3, serous clear cell undifferentiated mixed basonephric like gastrointestinal mucinous type and carcinomas. Nuclear atypia excessive for grade rises the grade of grade 1 and grade 2 by 1. When molecular classifications remains P53 abnormality or polymerase epsilon mutation status in stage 1 and stage 2, this upstaging or downstaging of the disease. If the molecular subtype is known, this is recorded in FIGO staging by addition of suffix M for molecular classification. In case of ovarian involvement, in case of high-grade tumors, ovarian involvement is almost always categorized as metastatic. And in case of pelvic peritoneal metastasis, 3B, and extra pelvic peritoneal metastasis, it is 4A. The accuracy of imaging techniques for diagnosing endometrial cancer. The infrared ultrasound cervical stromal involvement is 69% accuracy and myometrial invasion 68%. Distance spread is very poor by ultrasound. MRI is distant metastasis is good. Myometrial invasion 90% we can appreciate and cervical stroma involvement is 80%. Contrast is very poor in seeing the cervical stroma involvement, whereas myometrial invasions and distance spread is good. So MRI is better option. Management of endometrial carcinoma. The treatment modality is surgical, adjuvant, and targeted therapy. Surgical is hysterectomy plus bilateral salpingo-oophorectomy and lymphadenectomy. This may be sufficient treatment for in case of low-grade tumors, early stage diseases, stage 1, stage 2 endometrial cancers. If it is high grade, we have to go to adjuvant therapy and targeted therapies. So other adjuvant therapies are radiation therapy, vaginal brachytherapy, or external beam radiation, and chemotherapy is carboplatin or paclitaxel, commonly used for advanced stage or high-risk disease. Hormonal therapy is progestin for fertility preserving in young patients, and targeted therapies are mTOR inhibitors and immune checkpoint inhibitors. So the prognostic factors are, it's depending upon the grade, biometrical invasion, lymph node involvement. Survival rate is more than 90% for early disease and less than 20% for advanced disease. Follow-up and surveillance every 3 to 6 months for first 2 years and annual examinations thereafter, and images as needed based upon the clinical examinations. We have to do obviously molecular stagings. First, we have to see the decisions to use molecular staging depends upon the availability of sources and multidisciplinary teams of each center. We have to do polymerase epsilon sequencing. If there is no core hotspot mutations, we have to go for DNA MMR protein immunohistochemistry. Expression loss means it is a microsatellite instability high. If it is expression is retained, we have to do P53 immunohistochemistry. If it is normal, it is copy number low. If it is aberrant or mutant pattern, it is copy number high. So coming to surgeons, the mainstay, we have to do total abdominal hysterectomy, bilateral sulfate-oophorectomy, and lymphadenectomy. Surgical staging by visual inspection and cytology by peritoneal biopsy and recommended. Total abdominal hysterectomy and bilateral sulfate-oophorectomy and lymph node assessment standard options. Fertility preserving surgeries options for early disease. Ovarian preservations in perimenopausal women, stage 1A and 1B, may be safe and not associated with increased cancer related with mortality over 16 years follow-up. And criteria for normal looking ovaries, early stage disease, no personal or family history of breast and Lynch syndrome. Lymph node assessment is a prognostic factor maybe after treatment decisions. The pelvic lymph node dissection with or without para-aortic lymph node dissections. Para-aortic lymph node evaluations in case of high risk tumors. Stage 1A and grade 1 or 2 lymph node sampling is usually not recommended. Sentinel lymph node mapping with ultra staging is associated with increased lymph node metastasis detection, less false negative rate, and less morbidity, less systemic lymphadenectomy, and endocrine green technique. These are the principles of evaluations of sentinel lymph node mapping. Common cervical injection site for mapping uterine cancer. Most common locations of sentinel lymph node is this following cervical injections. These are the figures steps we have to do. And peritoneal and serosal evaluations and washing, retroperitoneal evaluations we have to be done. Accession of all mapped sentinel lymph nodes with ultra staging. Any suspicious node must be removed regardless of mapping. If there is no mapping on a hemipelvic site-specific lymph node dissection is performed. Para-aortic lymph node dissection done at the attending dissection. So, initials, this is limited to the interest. It's a patient suitable for primary surgery like TH with BSO and surgical staging. Adjuvant treatment depending upon the staging, stage 1, stage 2, stage 3 or 4 are incompletely staged. We have to follow up the patients. Patients decide fertility sparing options we have to be considered. Patient is not suitable for primary surgery. We have go for radiotherapy, vaginal brachytherapy, or external beam radiation therapy, or prefer or consider hormone therapy, including progesterone IUD in selected patients, and for surveillance. So, coming to the figure staging and treatment. If stage 1, if it is grade 1 and grade 2, observation after TH with BSO, observation is preferred, or consider vaginal brachytherapy if lymphovascular space involvement and or age is more than 60 years. In case of stage 1A and grade 3, go for vaginal brachytherapy is preferred, or consider observation if no biometrial invasions, or consider an external beam radiation therapy if age is more than 17 years more, or lymphovascular space involvement. If stage 1B, grade 1 vaginal brachytherapy is preferred, or consider observation of if age is less than 60 years and no lymphovascular space invasions. Grade 2 is vaginal brachytherapy is preferred, or consider external beam radiation therapy if age is more than 60 years and or lymphovascular space invasions, or consider observation if the age is less than 60 years or no lymphovascular space invasions. If it is stage 1B and grade 3, we have to go for external beam radiation therapy or vaginal brachytherapy with or without systemic therapy. So the criteria for considering preserving the fertility sparing options for management of endometrial cancer, all criteria must be met. The first is well differentiated endometrial adenocarcinoma on endometrial sampling, that this is limited to the endometrium on MRI preferred or transvaginal ultrasound, absence of suspicious or metastatic disease on imaging, no contraindications to medical therapy or pregnancy, and patient should undergo counseling that fertility sparing option is not standard care for treatment of endometrial cancer, and follow-up should be needed for these cases, and consultation with expert fertility prior to the therapy, recommended genetic evaluations of tumor and evaluations for endometrial cancer risk, and ensure negative pregnancy test. Continuous progesterone-based therapy you have to give. Either you have to give megestrol and medroxyprogesterone, acetate, or progesterone intrauterine doses marina, and weight management, lifestyle modification counseling should be done, and endometrial evaluations every 3 to 6 months has to be done, either by endometrial sampling, complete response by 6 months, and page conceptions with continued surveillance, endometrial sampling every 6 months, consider maintenance of progesterone based therapy if patient is not actively trying to conceive. Then go for T8 with BSO with staging after childbearing complete or progression of disease on endometrial sampling. Ovarian preservation may be considered in selected perimenopause patients. Whereas endometrial cancer present at 6 to 12 months of follow-up, we have to go with total abdominal hysterectomy with GSO with staging, and ovarian preservation may be considered in selected cases. In case of suspected or gross cervical involvement, we have to go for cervical biopsy or pelvic MRI should be done. If it is negative results, we go with surgical therapy and surgical staging, adjuvant therapy like stage 1, stage 2, stage 3, depend upon that. If it is positive result suitable for primary surgery, you have to go with the total hysterectomy along with a radical hysterectomy or BSO or surgical staging. Or we can go with external beam radiation therapy or brachytherapy. Or if it is not suitable for surgery, you directly go for external beam radiotherapy or brachytherapy and systemic therapy, or go with systemic therapy. If surgical resection is rendered possible, surveillance we have to do that. Surgical resection, if rendered operably, external beam radiation therapy plus brachytherapy, it's still unoperable. In case of incompletely surgical staging, stage 1A, grade 1, grade 2, no lymphovascular space, age less than 16 years, just observe. In stage 1A, grade 3 and age less than 16 years, no lymphovascular space invasion, no myometrial invasions, just observe. Other cases, we consider special hysterectomy in case of stage 1, grade 3 or stage 1B, grade 1 to grade 2, and age more than 60 years and no lymphovascular space involvement. In case of lymphovascular space involvement, they have to do imaging studies and surgical re-staging should be done. Depending upon that, we have to go for adjuvant therapy or consider the brachytherapy or external beam radiation therapy. Surgically targeted stage 2. Stage 2, grade 1 to grade 3, external beam radiation therapy is preferred, and vaginal brachytherapy and systemic therapy is preferred. In case of surgically stage 3 or 4, systemic therapy, external plus or with or without external beam radiation therapy or with or without vaginal brachytherapy should be considered. So in case of relapse, a local regional recurrence, negative for distant metastasis on radiological imaging, no prior radiation therapy to the site of occurrence. Go for external beam radiation therapy without brachytherapy or systemic radiations. This is confined to the vagina, paravaginal soft tissues. Go with radiation therapy along with systemic therapy. So coming to advanced case of distress, we have to consider with systemic therapies. We have to use chemotherapy like carboplatin or paclitaxel, the current standard of care. Or we can go with bevacizumab also we can do. Hormonal therapy, grade 1, grade 2, or estrogen receptor, progesterone receptor positive cases, we can go for progesterone, progesterone acetate or megestrol acetate or marina we can use. Anti-estrogenic agent tamoxifen, letrozole we can give. And 2/3 of second and third line of therapy is poor performance status. 25% of case status, we can go with medroxyprogesterone acetate and plus the tamoxifen citrate. And 32+ responsive cases, everolimus and letrozole. Targeted therapies, biomarker directed systemic therapy for second line treatment, levantinib or pembrolizumab for non-microsatellite instability high or non-MMR deficient tumors, pembrolizumab or for Microsatellite or microsatellite instability tumors. So the risk is low risk is stage 1, grade 1, grade 2 with endometrial type and no focal lymphovascular involvement. High risk is all stages and all histologicals with P53 abnormality and myometrial invasions. So coming to summary, the treatment policy changed according to the molecular levels. The new staging and molecular levels both changed the policy. Protect 4A may be given a new dimension. The role of treatment intensification or dose de-escalate patients will be answered by Protect rainbow studies. Thank you.